And as a COPD patient, she's definitely felt some of the effects of having COPD and having had this pneumonia and how they've affected her health. She's at much higher risk of other complications like the flu and pneumonia, and so she's a wonderful inspiration for all of us who are researching to prevent these causes because, frankly, I've grown quite accustomed to her, and I want to have her around for as many years as possible. She's been diagnosed with both pneumonia and influenza multiple times, and both of these have affected her breathing and her overall health. She has been a tireless ambassador for lung health issues. She and I are on a bit of a speaking tour together, and she talks a lot about having COPD and being a breathing ambassador for the Lung Association. So having had these experiences with pneumonia and influenza, she's also a very passionate advocate for immunization, and it's my honor and privilege to invite her up here to speak to us today. Thank you, Bev.
No, I can walk. Where do you want me to go?
Yeah. Do you want to stand by the podium?
I guess so.
It's up to you. If not, you can
Yep,
have
I'm
a
okay.
seat. Yeah? Okay.
Yep. Where are we going to?
Here, if you need me.
Huh? Oh, okay. I'm here?
You're here, my dear.
Oh, dear Lord.
Whatever's better for you, but
Hi, everyone. I'll give it.
do you want to sit here? There, and
Okay.
just share your story. It's good.
Hi, everybody. My name is Bev Black. I'm now 76. January 2009 was a big eventful year for me. I get emotional. I was in the hospital 7 weeks. My daughter was expecting her second child. And I didn't know if I was going to come home or not. But by the grace of God, I did. And I thought I was down to 72 pounds. And over the years, with the support of amazing doctors that talked to me, not at me, I've been able to bounce back. The support of my daughter, who's here with me, Shelby, has been phenomenal. And of course, the support of the Lung Association of Ontario. I could pick up the phone, call, ask questions. They were always there for me. And being a lung health ambassador, it gives me a sense of purpose, which I think we all need in those golden years. Other than that, I do the pneumonia shots. I do the flu shots. I've had pneumonia twice, bad, hospitalized twice. And I've had the flu about 3 times. But I've been fortunate enough to bounce back from them. I take my time, I do as I'm told, reluctantly sometimes. But here I am. So are you going to ask me some questions?
We're going to ask at the panel session.
Okay.
So I think...
You want me to?
Yeah, you can sit back there for... or
My- No, wherever you want me.
Okay, yeah, if you can sit back here, and then we'll come back up to the panel after the break. Thank you so much, Bev. Thank you for sharing your story with us. And there will be a panel session where we can ask Bev some questions about her patient experience. Our next speaker, Dr. Natasha Crowcroft, is the Chief of Applied Immunization Research and Evaluation at Public Health Ontario. She's a professor in laboratory medicine and pathology at the Dalla Lana School of Public Health, the University of Toronto. And she's an adjunct scientist at the Institute for Clinical Evaluative Sciences. Dr. Crowcroft's research aims to maximize the health benefits of immunization. She's published over 230 scientific papers on the topic and provides expertise for national and international authorities, including the World Health Organization. Please join me in welcoming Dr. Natasha Crowcroft.
Thanks so much, Dawn. I don't think I need to stand here, do I? Because I'm mic'd up, yeah. So I might walk around a bit. And thanks to the Lung Association for inviting me to speak. I'm absolutely thrilled to be here, and it's lovely to see some familiar faces and to meet some new ones, and very inspirational to have you speak, because I lost both my parents to smoking-related diseases, so it's kind of a bit, oh, sorry, John. It's quite emotional for me to hear about people who've actually managed to overcome all the challenges and of smoking addiction, which is very, very hard to do. So I take my hat off to you and thank you. It's very hard, I know. I spent years trying to get my parents to stop and it didn't work. So So thank you. I think I'm going to kind of set the stage for two of the speakers who are coming later as well. Dawn, it was a lovely introduction. You've kind of given the context, and George as well. You're going to get a lot more information from the following speakers. I'm working at Public Health Ontario, the provincial public health organisation, and we have a provincial role that supports people working at local level. I know there are some people here from the local public health units who also have an essential role in this area. And I'm really pleased that this initiative today is happening because I think it's so important for the health of seniors. And just to say, I don't have any affiliations with a pharmaceutical medical device communications organisation. So I had two goals for my presentation. First was to talk about a whole-of-life approach to immunisation, and why that's important, and then to talk a bit about why immunisation rates are so low. So before I start into that, I just wanted to say something really simple. Like, why do we recommend vaccines? It's really, really simple. Everyone in the room I know knows this, but vaccines save lives. That's why we recommend them. It's not because we want to make money for Big Pharma. It's not because we want to save money. It's because they save lives. So why a whole-of-life approach? Well, as we were just hearing, health needs, they change as we get older. So we know that there are things that change in the immune system and in our lives that mean we need to think about the whole of life. And immunisation is traditionally really focused on kids. And that's where the driving force has been. The other angle of this that I'll say a bit more about is that things do change as people get older, and we have kind of neglected the seniors, I think. But we actually shouldn't really be thinking necessarily of just switching all our focus to seniors, but thinking about immunisation as protecting the whole of life. And I'll say a bit more about that as well. So some of the things that change as we get older, well, we know influenza increases the risk of acute myocardial infarction. There was a very nice paper that came out from, led by one of my colleagues, Dr. Jeff Kwong at ICES, showing the link with acute myocardial infarction, so heart attacks. We know influenza causes Guillain-Barré syndrome. People are worried about the vaccine causing Guillain-Barré syndrome. You're much more likely to get Guillain-Barré syndrome from influenza than from the vaccine. Pneumonia we've heard about, all the things pneumococcal disease causes, which you'll hear about later. There are, two of my vaccines have always been diphtheria and tetanus. And diphtheria is one of those things, it's incredibly rare, but the only cases I've been involved with of classical diphtheria have been older people who took cruises to exotic places because they'd retired, hadn't got their immunisations up to date, and came back with diphtheria. Very rare. But I've dealt with those cases, not in Canada, but in the UK. Tetanus, classically, gardening, you start gardening more, you get older, you haven't got your vaccines up to date. So they are things to think about. And then shingles, which is incredibly common, but we're focusing on respiratory disease, so I'm not going to say much about that. We have national targets for immunisation coverage. And the coverage goal for influenza is 80%. That's based on the importance of protecting high-risk Canadians and also as part of infection control in hospitals. And it's for adults 65 and older, so we've got your seniors, and then this whole-of-life approach, adults with chronic conditions who are 18 to 64, and healthcare professionals. So we have a national target of 80%. That's for flu. We also have a target for pneumococcal disease, which is a little bit simpler because it's one dose of a pneumococcal vaccine, and it's only for adults age 65 and older. So we have national targets. That's great, 80%. That's high. Which of the vaccines are actually publicly funded for adults in Ontario? So we have influenza, which is including in pregnancy. You may think that sounds a bit of an odd thing to talk about pregnancy in something on seniors, but I'm going to explain a bit later why that's important. Diphtheria, tetanus, polio, diphtheria, tetanus, pertussis, only one dose is funded. And in fact, other vaccines that you want to think about, MMR, your healthcare professional can give you a dose of measles vaccine if they think it's needed. Very unlikely anyone who's older, but something to think about. And then the shingles vaccine, Zostavax, pneumococcal polysaccharide vaccine, and then for other high-risk groups, those are the 18 to 64-year-olds, a range of vaccines according to their risk group. So that's what's publicly funded. Now, I wanted to talk about pregnancy, and I'll tell you why. It's because I think we have, we're going to talk a lot about influenza vaccine, but seniors are an incredible advocacy group. And so if you have grandchildren or you have grandnephews or nieces, this is an opportunity to say, listen, guys, you should get your flu shot to protect me. And if you're pregnant, you should get your flu shot to protect you and your baby and me. So I know it's maybe a bit out there, but I thought I'd talk about it because we need to think about things from the whole of life perspective and from the whole of family perspective. And a recent paper came out, if a woman gets vaccinated in pregnancy, her risk of being hospitalized with influenza during pregnancy is down by 40%, which is really important. You don't want to be hospitalized when you're pregnant. There are some vaccines that are recommended by the National Advisory Committee on immunization, but not funded. So there's a Shingrix vaccine, which is a different shingles vaccine. In fact, the vaccination for whooping cough in pregnancy isn't funded. And then some types of influenza vaccines for some groups are not funded. So the high-dose flu vaccine for healthy adults is not funded, for example. And then there are some vaccines that are recommended, they're not recommended by NACI and not funded. So the recent conjugate pneumococcal vaccine for healthy adults more than 65 years of age. So that's a bit of a subtlety because it's, there's a big difference between publicly funding a whole program and what's good for an individual. And this goes back to the Shingrix argument that if you have a vaccine that public health says we haven't got the money to pay for this for everyone, it might have an edge. You as an individual may be better off having it. Then it gets tricky because public health won't fund it and most people won't be able to get it. It's a huge equity issue. But your physician actually has an obligation, according to the Canadian Medical Protection Association, to let you know, here's the vaccine I can give you that's free, but there is a better option for you that you would have to pay for. So pertussis is one of my pet obsessions. So just to say, older people can get whooping cough, and it can be horrible. So everyone should have a dose of pertussis-containing vaccine as an adult, and one dose is funded in Ontario. And if you've got grandkids, you might want to think about it as well, because you can give pertussis to your grandkids, and you can get pertussis from your grandkids. So pertussis is whooping cough. And, but then there's this pregnancy recommendation. And again, one of the best sources of information on what to do when you're pregnant comes from your own mum. So if your own mum says you should have this vaccine, then that's a great recommendation. So advocacy is really important. And vaccination in pregnancy is greater than 90% effective at preventing whooping cough in your baby once the baby's born. So I was asked to speak a bit about economics, but I'm not an economist. So what I wanted to say was that vaccines make economic sense, as I said, not because they put money into the pockets of big pharma. They make economic sense because they keep people healthy and keep them out of hospital. So that's, they do save money, but they only save money really for communities by saving our health and keeping us healthy. So going on to how we're actually doing in terms of vaccine uptake. And here we get to the bad news. A survey that was carried out by the Public Health Agency of Canada in 2016 asking about vaccine uptake in Canadian adults. Just over half of adults reported having been vaccinated. Over 80% if they'd had a wound in the past year said, oh yeah, I had a wound and someone gave me a tetanus shot. So that happens. But only 54% of adults reported having like a routinely up to date. Only 10% of adults reported having had the pertussis vaccine, the whooping cough vaccine. And interestingly, most adults said they thought they knew enough about the benefits of vaccines. Okay? We all kind of overinflate what we think we know. So 88% of adults believed they were up to date on their vaccines, but only 3% actually reported having received the correct number for their age and risk group. So, we have a real problem here. Not just that uptake isn't big enough, and it's not that everyone's out there saying, I don't believe in immunization, I'm not going to have my vaccines. People are actually walking around thinking everything's okay. They've had everything they need. They don't need anything else. They've had the correct number. And they are wrong. They're just wrong. really, really wrong. 3% were right about having had the right amount. So we have a real issue. So what is coverage at the moment? Well, this is 2004 to 16 data. And this is data in 65 plus and high risk for comparison. And you see for 65 years and above, you've got 65% coverage in 2016. So going back, and this is for influenza vaccine, so going back to what I said earlier, we have an 80% target nationally, and we're hitting 65% in 65 plus. So sorry, I don't know if you can see the bars there, but it's the dark blue bars are the 65 plus, because the legend's a bit small, and then healthy, and then adults with a high-risk condition, is only 41%. So these are adults with a high-risk condition, and if you take that all-of-life approach, again, we have an issue there. And then this is broken down with healthy. This is including healthy adults and adults with medical conditions. Those without, it's even lower. So 25.1% in 2016-17. So nationally, we're doing really badly on immunization coverage for flu. And then 65 plus, you've got 69.5 on this in this analysis. And then pneumococcal vaccine coverage, and this is just 65 plus because that's where we have a national target. And there we're doing even worse. And this I find curious, because this should be easy. You only have to have one dose. And it's a straightforward vaccine, and it's not really controversial. I mean, I'm endlessly hearing about issues with flu vaccine, but nobody comes up to me saying, have you heard about that pneumococcal vaccine? It's really controversial. Does it work? Is it, nobody does that. Why? So this should be 90%. I don't understand it. I completely don't understand it. So why do people get a seasonal flu vaccine? So here are the reasons that were given in the survey. To prevent infection, seems sensible. Those who had chronic medical conditions said, oh, I'm at risk, so I need to get this vaccine. Adults age 65 or older, a lot of them said, oh, well, I get it because I get it every year, okay? That's really important information. So their doctor's probably saying, every year you've got to get the flu shot. They say, every year I'm going to get the flu shot. They're the people going every year and they get the flu shot. So having ways of encouraging that idea, that thinking, it's normal. Every year I get the flu shot. Receiving a recommendation from a healthcare provider, this is where the people in this room can be incredibly important, was also really, really, if your healthcare provider says, get your flu shot, then that's very important. Why do they not get the seasonal flu vaccine? So consistent finding in all age groups. So it was with or without chronic condition. This is everyone saying similar things. Nearly half said they don't need it. They're not at high risk, and it's not recommended for me. So including people who self-identified at being in a risk group said, I don't need it. It's not recommended for me when it is, okay? And then up to 20% did not believe in the vaccine's effectiveness across the different groups, so it doesn't work. I mean, that's understandable when you think of the barrage of media stuff we hear about how it doesn't work. And then 10 to 16% said they had no time. That's interesting because 10% was in the seniors, said they didn't have time to get a flu shot. And I'm not that sounds funny on one level. On another level, it's great. It's because they're probably, it's like, I remember the government of the UK brought in this system for checking up on the health of seniors at home, where people were supposed to go into the home and make sure they were okay. And the biggest challenge that healthcare providers had in delivering this program was that the seniors were not at home. They were out doing things. They don't just sit around at home waiting for somebody to knock on their doors. So, it's great. Why are immunization rates better for kids? Well, there's this huge collaboration of people, and there's a single professional group, like specialty, pediatrics, that's totally behind immunization. And you have all these different organizations pushing for immunization. A lot of them will push for seniors as well, but there is that same driving pediatric thing. We don't have that in immunization. We really need it for seniors. If you go, once you're getting healthcare from seniors, you're seeing such a range of different people. There isn't one group, like pediatricians are all behind this, but you could be looked after by a cardiologist or by, anyone, any specialty of medicine. So there isn't that sort of concerted group thing. The good news is that Canadians trust their doctors. So if this is Canadian parents, but I think it reflects society in general. Where do they go for information? 68%, the most reliable and trustworthy information is coming from their physician. So they trust their physician. They do look at the internet, but they don't trust as much, so that's, they're sensible. People are generally sensible. And then there's family members, other healthcare workers. I was interested that scientific sources and research studies is rated about as high as the government for being trusted. Kind of puts people like me in my place anyway. It's, but physicians are up there, so, and family friends, so that's really important. So the question is, what do we do about all this? We have, issue of trust, we have a disorganized situation, it's lots of challenges. So, what's the solution to this problem of how do we get coverage up for seniors? And I think really part of the solution is you. People like you, organizations like the Lung Association, it's really, really vital to get a groundswell of people supporting action and a coordinated response. So there was this really nice headline recently, Save a Grandma, Get Your Flu Shot. And I said, with a whole of life support, it's not just about saving your grandma, it's about your grandma saving your grandkids. It's about, everybody in this together, families in this together, and ensuring we all stay healthy. So I think, you have a friend who's sick, you need to make sure everybody, my kids were at McGill and we were going back to the UK to see a friend who was very sick. And of course they were in Quebec, so they didn't get their flu shots. So it was like the moment they arrived back in Toronto, before we got on the plane, I kind of frog marched them into the pharmacy, got them vaccinated, and then a week later we were in the UK. So, you have to really think about this. They're fine, actually. They're very pro-immunization, surprisingly enough. So it does take a whole community to make an immunization program successful. And this is a group, the seniors are a group we've really neglected. So what I want to say is that if everyone in this room supports immunization, we have unknown effects on everybody else in the world. These things spread, and we need to speak up. And when people say little things, all you have to say is, well, I get my flu shot. I get it every year. I wouldn't want to give it to anyone else. I wouldn't want to give it to someone I lost my... I wouldn't want to, I wouldn't want to make anyone else sick, and I don't want to get sick myself. So, same with pneumococcal disease. Have you heard of the pneumococcal vaccine? Do you know it causes meningitis? It causes, anyway, you'll hear more about that later. This is, vaccines save lives. So all the people who are supporting immunization to me are silent heroes who every day, by supporting immunization, are saving lives. You'll never know whose life you might have saved, but you're saving someone's life somewhere. So that's a beautiful thing. It's terribly soppy, but that's me. So thank you. That was... yeah, I mean, no one likes needles, but, we get over it. So happy to take questions. Thank you. Okay, sorry.
We'll do questions at the panel session. So that was wonderful. I love that life course idea. And I think if Bev Black can make the time with all her advocacy work, then the rest of us will make our time for our vaccines too. That's wonderful. Thank you. Our next speaker is Dr. Samir Sinha, a passionate and respected advocate for the needs of older adults. Dr. Sinha currently serves as the Director of Geriatrics at the Sinai Health System and the University Health Network in Toronto. He's also involved in the Peter and Sheila Godso Chair of Geriatrics at Mount Sinai Hospital. He's also an associate professor in the departments of Medicine, Family and Community Medicine, and the Institute of Health Policy, Management and Evaluation at the University of Toronto. And it keeps going, my friends. That's right. He is also an assistant professor at medicine at the Johns Hopkins University School of Medicine. So with that, please join me in welcoming Dr. Samir Sinha. Thank you.
So thank you very much and good morning, and it's a real honor. The reason why Bev I hope you did get your flu shot this year because you're on a speaking tour. Absolutely, but here's an example of an active older adult, and it explains kind of Natasha's theory as to people aren't home because the goal is if we can keep people healthy and active, they can be out in the community. So you know, building on Natasha's comments, you know, one of the challenges that we always have is you know, why are we doing such a poor job of around vaccinating older adults? And so for those of you who haven't seen a geriatrician, this is one of the challenges. There are 10 times as many pediatricians in Canada as there are geriatricians. Yet in Canada now, we have as many older people as we have younger people. So we have big disconnects, and I think that's one of the challenges that we have when we start thinking about why are we doing so well when we think about vaccination in younger populations, yet we do so poorly when we think about, you know, older populations and making sure that they're just as equally supported, and a lot of big disconnects. So I'm really proud to be a founding co-chair of the National Institute on Aging based just across the street at Ryerson University. Michael Nyssen is our executive director, and one of the key things is as we started working on policy issues, it's a policy think tank where we're trying to think about, you know, issues related to the health and well-being of older Canadians. One of the big things we started focusing on was a pillar of activity really around healthy and active lives. And really, and this is where we started zoning in on this whole disconnect, you know, as Natasha helped to pinpoint around this just disconnect that we have between why do we do so poorly around vaccinations and what do we do. And really, this was a white paper we came out with that we're actually relaunching today, which really speaks to this underappreciated burden of influenza around and amongst Canada's older population. So a little information about the NIA. As I said, it was established in 2016, and we really focus on policy innovation and advice to promote best practices for aging well. And really, we try and think about thought leadership, innovation solutions, and public education and public policy related to aging. And I mentioned to you that we have 4 pillars of activity that support the work that we're promoting federally to support the idea of a national senior strategy. And we've been working hand in hand with the federal government to really help give them policy solutions that really help move things forward. And so one of our pillars of activity is around healthy and active lives. And this is the work that we've really been spending the past year and into next year focusing on topics of immunization, not just around things like influenza, but also pneumonia, shingles, many of the topics that, that Natasha just mentioned, if you will. So this is the report, and I'm sure that we'll be able to circulate it to those who have our new updated version that comes out today. And this was supported with an unrestricted educational grant from Sanofi Pasteur. And really what we wanted to do was really characterize the actual burden of influenza amongst older Canadians, explain the current state of the evidence around policies in influenza immunization in Canada. Because as you quickly start thinking about it, you know, when you think about, you know, countries like the UK, or Denmark, you know, they have national policies and they have national health systems. When you start realizing how we actually think about immunization policy, you know, as Natasha mentioned, we have a group called NACI that says, here's what we recommend for all Canadians, but then it's up to each province and territory to determine what's covered, who gets what, and you start realizing very quickly that we don't really even have a national strategy around immunization, and then we start seeing very differential rates of vaccination province to province, territory to territory, and it gets really complicated very, very quickly. And so that was a real eye-opener for me and our team as we worked on this report. And then, of course, we think about how do we do? We have this target of 80%, but then how does Canada rank against other countries around the world? And you actually start realizing we're not doing as well as we should be doing for a number of reasons. And there are a number of reasons behind that as well. And so then we came up with some recommendations to really start thinking about how, as a country, we could start moving forward to advance the policy and practice agenda, and I'll share those with you today. So again, what we do is we actually will interview some of the experts that you've heard from in the room today. And in terms of working on this policy report, these are some of the folks, including Alison McGeer, who will be speaking after me as well, Jeff Kwong, many of the folks who are thought leaders and experts on these topics as well. And then really thinking about how we can actually work on this as part of an overall series as well. So you've already heard a little bit from Dawn and Natasha, really about the the burden of influenza in Canada, and you heard how Dawn mentioned how influenza or pneumonia really is one of the only infectious diseases that's one of the top 10 killers in the country. And just to help rank this, it's just behind diabetes, right? We hear a lot about the diabetes epidemic, but there's influenza pneumonia, the 7th leading cause of death in Canada, and ahead of dementia. Everybody's scared of dementia, right? People are concerned about diabetes, but right there in between those two significant illnesses that we're thinking about sits influenza pneumonia. But people don't often think about it, right? They don't think that that's what's actually going to do me in. They are worried about these other issues as well. So it's helpful to have that image in mind. And when you heard a little bit about the burden of influenza already, and just to put that in perspective, a lot of people we find say, well, I had the flu last year, and they actually equate the flu with the common cold. I think a lot of people underestimate what the flu actually is, and sometimes they actually don't realize that the flu is actually something that is actually a significant illness, and it's something that can kill. And if it doesn't kill you, it'll probably hospitalize you. So we're talking about up to 12,000 hospitalizations annually from the flu alone. And we're talking up to 3,500 deaths a year. I remember, I don't know if Allison is here in the room already, but there was the big report that came out in the US, which does a really good job of tracking data. And they actually said that last year during that influenza season, which is one of the worst on record, they had about 100,000 deaths that they had identified because of this. And I said, well, what was our, we have a number of deaths that occur in Canada, but do we think it was that high? And I remember Allison told me, we do a terrible job of collecting data here, so we don't even know the impact. And that's the problem. When we don't know the impact of how many people got the flu last year during a serious flu season, how did that affect the health system? It's hard to actually deliver change. But again, we have to appreciate that while it's a significant driver of death and hospitalization in Canada, it's Canada's leading cause of death amongst vaccine-preventable diseases. And this is the key thing. As Natasha was saying, we have a pneumonia vaccination. You just need to get it once. Yet so few older Canadians have received it, right? And again, when we think about influenza being one of Canada's leading causes of death, this is a real challenge and a real opportunity at the same time. So we also think about influenza in terms of its impact on our economic productivity. Because sometimes we think about, okay, well, if it's an older person, well, maybe they're retired, so what's the big deal? But you already heard how Dawn was saying, well, older people are significant contributors in so many ways in our society. Actually, more and more of them are actually in the workplace, number one. More of them are on speaking tours, like Bev, right? Playing with grandkids on cruises, doing things, maybe providing childcare, significant volunteers, but influenza affects people of all ages, right? And for those who are working Canadians, we're talking about 1.5 million lost work days every year. And when we're talking about economic productivity, this is where we need to think about how this doesn't just affect the health system, but it actually affects our overall economic productivity as a Canadian. So this is why the Minister of Finance needs to be interested in this. And I think Dawn and I were mentioning how in the fall economic statement for Ontario, they focus on pneumonia as something that actually drives other costs because it's an economic issue for our provinces and our territories and our country as a whole. You already heard a little bit that there are a lot of people, there are a lot of groups, anybody who has a chronic condition, a significant chronic condition, is at a higher risk of influenza. And then generally, the populations, those who are greater than 65, those who are less than 5. So there are a lot of groups that make you at higher risk for influenza. Yet, I think as Natasha pointed out, a lot of people don't actually see themselves as being at high risk, even though there's significant proportions of our population that are at high risk. So why are we not doing a good enough job really making it very clear for people to self-identify and probably for their healthcare providers to help them recognize that they are at risk and why it's important? Okay. We also know that when we start thinking about influenza and why we think a lot about influenza at the National Institute on Aging is because we know that those who are better than 65 suffer a disproportionate burden of influenza. right? So we know that, for example, those, for example, who are hospitalized with influenza, the majority of them had an underlying chronic health issue. That's why we need to focus not only on those who are 65 and better, but also those who may have an underlying chronic health condition. We also know that the majority of those who actually die of influenza, again, had an underlying chronic health condition. And we know in general, it's older adults who actually suffer most of the burden of influenza, hospitalizations, and death as well. So we need to actually appreciate that and understand why that's important. And we know that the reason why people always say, well, why are older adults more vulnerable to this as we age? And I think part of the thing that we don't appreciate is that as we age, our bodies change, they evolve. And we can't mount the normal immune responses that we could have when we were younger, healthier adults. It's why we often appreciate, I think, as a society, that children need vaccinations because their immune systems haven't fully developed. But we start to realize that with mileage, as I like to say to my 95-year-old patient who was complaining about her knee the other day and saying, why is it starting to give me trouble? I'm like, they don't make cars that good anymore, right? They never made cars that good. So, think about it. But at the same way, our immune systems, they do a really good job for a lot of our life once they're fully revved up. But, then they need a little bit of help. And this is where those immunizations and that piece that Natasha was talking about, that life course approach becomes so important and so crucial. So when we start thinking about vaccination policies and outcomes in Canada, this is a lot of the work that we were doing through our report and our research, because we want to understand, why do we have such differential rates? What from a policy perspective, how can we actually help educate our government and our policymakers and our providers on what are the things that work and don't work, and where can we move forward? So first of all, we know that right now we recommend the influenza vaccination for Canadians, all Canadians over 6 months of age, right? And Natasha gave some additional examples that, again, it's important for all, for people of all ages and for multiple different populations. We also know that 7 provinces and territories provide universal funding. So we don't have provinces, we still have provinces in the country that don't actually provide universal funding, meaning that they're actually covering the basic influenza vaccination, across for their population. So that's a challenge, because we do have good evidence to say that universal funding actually is related to a higher uptake of the influenza vaccination. We also know that if you're living in Ontario here, you have the convenience, and this is one of the pieces of work I did under the government senior strategy here, was we actually recognized that we should give pharmacists the ability to actually provide the flu shot and the pneumonia shot and other vaccinations as well, because frankly, from a convenience standpoint, it'll actually work. And there's actually good evidence to support this. But we know that not every province actually enables pharmacists to deliver, for example, the influenza vaccination, but Ontario does. You heard Natasha was showing us some of the data of where we sit in Canada in terms of our vaccination rates. But when you actually start looking at us in relation to other major industrialized countries, this is a slide that actually shows where Canada ranks amongst a number of other countries. So we're better than Ireland, we're better than China and France, but we're actually far behind countries like Korea. South Korea is the only country in the world where they're actually meeting that international target of over 80% being vaccinated. But there are other countries like the United States, Britain, New Zealand, that are actually doing better than Canada in terms of their vaccination policies and actually their vaccination uptake around the influenza vaccination. People will be able to get copies of these slides afterwards in case you're squinting a bit too much to look at this. But again, it's fascinating when you see how we're related. And then the question is, why is that as well? So again, you heard already about our rates of vaccination, and again, the numbers and the stories are pretty much the same, but I just want to highlight a few things. When we actually look at where does Ontario stand, for those of us who are from Ontario, we're not the best province when it comes to coverage. Actually, Nova Scotia, currently, from our latest data, has the highest overall rate of coverage. Quebec, interestingly, has the lowest rate of coverage, and we'll talk a little bit about that as it relates to policies. But the other thing is you actually saw in Natasha's slides there, where you actually showed we were doing better with vaccination coverage a few years ago than we are now. We're actually on the decline, and actually we've seen that Ontario's rates have actually decreased over a certain period of time. So that's a problem, especially when we're getting more information to show how beneficial the influenza and other vaccinations like the pneumonia vaccination can be. So the good news is that if you're an older Canadian, you're more likely to get the vaccination, okay? So older Canadians 85 and better actually have the highest rate of coverage at 74%. But that's still lower than the official target rate of 80% or better. And then as you get younger and younger in age, we start seeing that those rates of actual coverage actually start decreasing, right? So again, the good news is that the older we get, maybe the smarter we get and the wiser we get, but we're still not where we actually need. And when we start to look at even differences amongst populations, forget just age alone, we found that there are differential rates of vaccination, especially amongst certain ethnic groups in our population. So we need to actually understand a little bit of some of the issues of diversity and how does that relate to vaccinations. I mentioned to you that there's good research out there that found that in provinces where pharmacists are able to administer the influenza vaccination, more people are actually vaccinated. That was one of the reasons why the Ontario government said we will now make the influenza and the pneumonia vaccination freely available and available in your local pharmacy. And we've actually seen over 1 million Ontarians receiving their influenza and pneumonia vaccinations in their local pharmacy, and we think that's been a success. The key is we don't actually have rapid data to actually tell us, how are we doing, so that we know what else do we need to do. So I think it's working. I hope it's working. I tell the Minister of Health that it is working, but we need better data, and that's a consistent story. One of the other things is that when we actually started looking at vaccination rates amongst healthcare providers, I apologize for the size of the slide, but only 50% of healthcare providers overall are vaccinated against the flu, right? Now, primary care providers, about 72%, of them will actually get the flu shot. That's pretty good. Specialist physicians like myself are a bit worse at 60%. And then you see other different professional groups, dentists, optometrists, et cetera. It's quite variable. And nursing's kind of in the middle, around in the mid-50s, if you will, about where it is. So the challenge is that even if we think about our national target of 80%, no physician group or healthcare provider group is doing that well. In fact, the best group to actually get vaccinated are those people who are working in long-term care. Those tend to be the healthcare providers that actually have the best achievable vaccination rates. So building on Natasha's comments, so why are we not actually getting the vaccination, right? What are the challenges? And so part of the work that we found was we built on the work of the WHO, the World Health Organization, again, that's trying to think about this, globally and trying to set targets of, again, that 85% rate of vaccination they want to see. And they had this really nice kind of framework to try and help explain why don't we get the vaccination, and not just the influenza vaccination, but others. And they talked about 3 things. Complacency, right? Again, you heard Natasha already talk about how people say, well, the risk of illness seems low, vaccination's not prioritized, right? I got the flu last year, that was that cold, that wasn't really the flu actually, and I'm healthy, I'm doing fine, what's the big deal, right? And mom hasn't gotten the flu in the last few years, so do I really need to get it this year? So we have a lot of complacency around this. People don't appreciate this as serious as it actually is. Convenience, right? Accessibility and affordability. This is a challenge. In provinces where this is not universally covered, right? Or in provinces where we don't make it easy for people to get their flu shot, for example, i.e. at the local pharmacy or in a variety of other ways. If we don't make it easy for people to do things, it's less of a reason to actually get that done as well. And then confidence, right? It addresses the issues of trust in the vaccine, the health system, and policymakers. I think as Natasha was showing, when those levels of trust, right? Science is almost trusted as much as governments, for example. But there was that key part that people, if their primary care provider or their physician, for example, says you should get the flu shot, people are really likely to respond to that. But what we realized in our research is that a lot of primary care providers, if only 70% of them are getting the flu shot, it means 30% aren't. And if they're not bothering to get it, are they bothering to tell their patients that they should get it too? And we realize that there's a really key disconnect that we need to work on, because again, people will do honestly what they'll want to do. So my patients know in my clinic, your arms are never safe. I screen for your vaccinations right at your first visit. If you're missing any, that's a focus right from day one. What are we doing about it, right? And especially now, even when they check in, they get asked, do you have, and if you don't, guess what's happening today? Either before or after you see Dr. Sinha or during the visit, you're gonna get some vaccinations, right? And again, and it's amazing. There's very little resistance. People are like, if you think it's good and these are the reasons why, I'll get it. And it's not that hard to do, but we don't prioritize it routinely as part of our practice. So finally, what were some of the key policy recommendations we've made towards our governments to thinking about this? And again, we always make this at a national level, but often we've had provincial governments that really look to these recommendations as well, based on the evidence that we actually think is clear enough to make a recommendation around. So number one, we recommend that we need to improve influenza prevention practices more generally. We need to really focus on that. And that really is around not only recommending the influenza vaccination, but also people washing their hands and doing other key pieces of hygiene to actually help to really focus on that. We need to really emphasize that very clearly. Natasha mentioned this already. We need to not think about vaccinations as just being for children, but we need to think about a life course vaccination schedule for older that includes older adults. So really thinking about making sure that in medical school, I think we all remembered, those of us who went to medical school and maybe schools of nursing as well, that you had to remember the childhood vaccination schedule, 18 months, 6 months, this is when you get that. I never had to remember anything about a vaccination schedule for older adults, right? But the key is if we teach everybody in medical school and schools of nursing, here's the life course approach to vaccinations, right? If it's drilled into our head, maybe that would make us actually more likely to recommend that to older adults. The key is, we've heard that one of the issues, but it's not the driver really, I think as Natasha showed, why people don't get the influenza vaccination is they say, well, I heard on the news that this year it's only 40% effective, or this year it's only 20% effective. But when I remind people that's 20 or 40% more effective than not getting it at all, people are like, oh, okay, I didn't think of that, right? So I guess it really is our best defense, and washing our hands, are the things that you can do. But obviously, the holy grail will be if we can get one core influenza thing, so you just get it once like we can do with the pneumonia vaccination. So we need to continue working towards developing that, and there's certainly a lot of research in that area. We also found that when we look at a lot of clinical guidelines for older adults and for treating chronic conditions, people often forget to mention the importance of, say, the influenza or the pneumonia vaccination. So it's often in situations where we're not doing that. And I know Allison, at our hospital, we make sure that in our COPD or our CHF care protocols, it's there, vaccination, pneumonia and influenza, but that's not necessarily a standard of practice. And that's partly because the current clinical guidelines, not in all cases, actually mention this. This was something I got annoyed about the other year, because this was a tweet that came out from the Ministry of Health in Ontario that basically said, adult vaccines, when to get them, right? And so, of course, for the people 65 and older, it said pneumococcal, it talked about shingles, it talked about tetanus and diphtheria, and I'm like, are we missing something, right? I mean, you have a whole campaign about this, right? And you kind of mentioned the influenza, right? So we pointed this out in our report, is that, we have to really mention that even the folks who really did a good job about thinking about this life course approach kind of forgot to mention one of the most important vaccinations that we're talking about right now. So what about the flu? Okay. Finally, we also said about providing clinical education and support for primary care providers and pharmacists to deliver vaccinations, making sure they appreciate how important it is for them to say it. Sometimes a primary care provider might say, well, you're seeing Dr. Sinha, I'm sure he'll take care of that. Or maybe the cardiologist or the respirologist, somebody else might take care of this. And we have to really make sure that you realize when you actually say it's important for Bev to get the flu shot, she listens to you, and it's really important that you actually make it part of it. How are our pharmacists making sure that they remind everyone to get the flu? And they do a better job because, again, pharmacies get incentivized to give the flu vaccination as well. on. Universal funding for influenza vaccination needs to be in place to ensure it's accessible to all Canadians. The evidence is clear, and if you look at our report, provinces that actually make sure it's universally covered actually have higher rates of vaccination. I don't know what else I need to say about that. And again, we need to make sure that, that all healthcare providers are basically getting the influenza vaccination. And we came out in our report basically saying that it should be mandated for providers and residents in long-term care homes. They already have some of the best vaccination rates, but there's very good evidence that all the people that we're caring for in long-term care homes are at high risk of influenza, benefit from getting the vaccination. And part of a good vaccination approach is making sure the people providing that care are vaccinated as well. And finally, we need to develop better and mandatory reporting of influenza vaccination rates, right? Because if we don't know this data quickly, we can't respond effectively, especially when we need to develop effective policies and practice. So for more information, you can always visit our website. You can follow us on Twitter. And I hope that just gives you a bit more perspective on how we've been thinking about influenza from a broader policy perspective, and maybe some concrete actions that you can help also advocate for as we move the bar forward. Thank you.
That was wonderful. Thank you so much, Dr. Sinha. We're going to have a break now until 10 after 10, and at which point we'll hear from Dr. Alison McGeer. If anyone's got any questions that they would like me to ask when we have the panel discussion on their behalf, you can come and tell me, and I'll make sure I ask them on your behalf if you don't feel comfortable. I'll see you at 10:10. Here's Dr. Alison McGeer. She is the Medical Director of Infection Control and Science Health System. She's a professor in the Department of Laboratory Medicine, Pathobiology, and the Development School of Public Health at the University of Toronto. She is a member of the Influenza Working Group of Canada's National Advisory Committee on Immunization. She served on the Infection Control Subcommittee of the Ontario Provincial Infectious Disease Advisory Committee from 2004 to 2018. And she's a member of several local, provincial, and national pandemic influenza committees. Please join me in welcoming Dr. McGeer.
I'm going to apologize ahead of time. It's always hard to follow these three speakers. Particularly difficult to say something new. And since I had to miss the beginning of it because I had to do something else this morning, I can't promise you that I'm not going to repeat some of what has already been said. Also going to apologize ahead of time for taking liberties with the title because I was asked to talk about the burden of influenza, but I actually think that everybody in this room knows the burden of influenza and believes the burden of influenza, so I'm not going to spend as much time on it as I'm going to spend talking about what I hope is a little bit different perspective on why we're having so much trouble with vaccines against influenza and what we might think about doing about it. So you can shoot me afterwards for going off on tangent. Okay. Well, let's start with talking about the burden of pneumonia. Pneumonia is actually a really difficult thing to assess because the only way we have of making a diagnosis is with imaging. And imaging tells you that there's something wrong with the lungs. But it's not actually very helpful with what it is. So you can, no matter what imaging you use, you can see that there's a problem, but it doesn't necessarily tell you it's an infection. And if it is an infection, it doesn't tell you what the cause of it is. And so it is much, much easier to talk about many other infections, both in terms of how you diagnose them confidently, and in terms of what you know about the organisms that are causing them, and as a consequence, what, say, the benefits of vaccines against one of those organisms is. So every time you open your mouth to talk about pneumonia, the conversation is naturally fraught. And you can use this as an excuse to either do things or not do things all the time, okay? It's a really significant issue. But it's also a very common disease. So these are data from the Conference Board of Canada estimating rates of pneumonia in different provinces and territories. The low is 175 in Nova Scotia. Clearly living in Nova Scotia is a good thing. You're more likely to get your flu vaccine, right? Less likely to have pneumonia. Highest in the territories. I actually don't think, I think this is a measure of how hard it is to measure pneumonia. My guess is that pneumonia is probably equally common in all these places. It's just a question how we label it, how we diagnose it, how we record it is different in different places. But it comes out at about 2 per 1,000, right? 200 per 100,000 every year. And where that puts pneumonia is in the top 10 cause of death. So number 3 in the world, number 8 in Canada. If you think about infectious diseases, really interesting how we assess causes of death. So in general, you'll notice that we've started to split out cancers when we talk about causes of death. So it used to be that we talked about cancer, heart disease, and then when we got to infections, we'd split out the infections into little tiny pieces, which would allow us to think that nobody died from infections because they were all way down the list, okay? So one of the things, so infections are actually summed together, number 3 cause of death in Canada. Okay, that's a lot better than number 1. Okay, number 1 was where we were 50 years ago, and being in number 3 is a very good place, but it's not great. Okay, number 8 or number 10 would be better. Okay, so, and top of the infectious disease impact is pneumonia and influenza. Difficult to separate because influenza causes pneumonia by itself. It's frequently complicated by pneumonia, so the two are inextricably linked, and that's why in causes of death we tend to list them as influenza and pneumonia. A very common cause of death in Canada, and when you separate out looking at burden of disease, right? So remember that Samir told you that you're much more likely to die if you're older and you have influenza. This is called welcome to the world, okay? You're much more likely to die when you're older, period. But it's not, when you look at the burden of infectious disease, you're not just interested in the causes of death, you're interested in years of life lost. So this is from Jeff Kwong's analysis for the province of the impact of different pathogens in burden of infectious disease in Ontario. And what you can see here is that strep pneumo and influenza are among the top pathogens causing, in this case, life years lost, not just causes of death. Okay, you're going to look at this and say strep pneumo is more important than influenza, and I will tell you that I actually think that in this study we substantially underestimated the burden of influenza, so I'm not sure that's true, but doesn't matter. They're both critically important. Pneumonia is also an important predictor of disability. So this is now an old study, but it's a study that looked at in patients who were hospitalized, what were the predictors of catastrophic and progressive disability over the course of the next year. And pneumonia figures in all of them, okay? It's a critically important cause in our system. For an adult who gets pneumonia, comes and spends 3 days in the hospital, 2% of muscle mass loss every day you spend sitting in my acute care facility, right? And then you end up not getting back to where you were before, and in nursing homes and falls, and it begins the downward trajectory that is end of life for many people. So the burden is not just death, it's not just life years lost, but it's also about disability and the misery of disabled life. Okay, so if that's true, and if we have a vaccine against pneumonia or against pneumococcal disease, why aren't we using it? So let's start with, this is a slide I put together looking at what we know. As Samir's already pointed out, our data on vaccine coverage is not what you would like it to be. So this is a combination of different sources looking at what data we have on adult vaccination coverage across Canada, okay? 1 C, 8 Fs, okay? This is, and I live in a country that prides itself in our healthcare system, in our vaccination programs, right? How can we be this bad? Really? system level, okay? So let's talk about the system issues with getting vaccines to adults, okay? So the first thing is that you always, for everything, we are human beings. And human beings are hardwired not to invest in prevention. Nobody buys enough life insurance. Nobody in this room actually recycles things to the extent that they know they ought to, right? None of us live up to the preventive things that we know we ought to do. And it's particularly difficult in healthcare because all of us who are healthcare providers are trained to respond, to treat. Okay? We don't spend nearly enough time thinking about prevention. And so thinking that we can fit preventive things into the healthcare system is actually a real challenge. It's not how we do business. And so the take-home message from that is all of us who are making decisions about what we do need to remember that we will systematically underinvest in prevention. What I tell my infection prevention students is that if you're not recommending more than you actually think needs to be done, you are not doing your job, okay? Because all of us instinctively underinvest in prevention. Our second problem is that we don't have a system for adult vaccination. When I first sat on NACI, the first afternoon we were there, I was the only adult person on NACI at the time. It was all pediatricians. And we spent the entire afternoon arguing about whether a booster dose was to be given at 12 months or 15 months. And I thought they were mad, okay? I didn't know what planet I had wandered into. I could not understand it, but now I do, okay? Because we have a system that is very carefully thought out to be simple and definitive, okay? And it's not the same as other systems, okay? So if you come here from the UK, kids get vaccinated at 2, 3, and 4 months in the UK, and we do 2, 4, and 6. And I don't know which is better, but I'm willing to bet there's a bunch of pediatricians who come from the UK who think 2, 3, and 4 is better. But when they get here, they take a deep breath and they say, this is the system. And systems, simple systems, are critically important because you can teach them to medical students, right? You can drill them through the heads of every parent who has a child in Ontario knows that they're going to turn up in their doc's office at 2 months for the first set of vaccines. Anybody in this room know when you're supposed to turn up at your doc's office for your vaccines? Okay. The last National Immunization Survey, 88% of adults said they were up to date in vaccines. Do you know what percentage of people actually were up to date? 3. Yes. You've been listening to Natasha. This is good, right? So as long as we don't, and you know, when we make recommendations at NACI for adult vaccines, we do all this fun thing. It's like, do you think we have to give a zoster vaccine at 60 or 50? Okay? So we have vaccines for 50-year-olds and vaccines for 60-year-olds and vaccines for 65-year-olds. And we've got this thing that says that if you're an internist and you just feel like giving this vaccine earlier, it's okay. Get past it, okay? So we're arguing about whether to recommend 50 or 60 and delivering vaccine to 15% of people, okay? This is dense, okay? But it's really hard for us to get past that. We really need, all of us who are interested in policy development really need to be working on building that. That system only comes with years of people working to make it so. We also have a whole bunch of structural barriers for payment, okay? You think about how we spend money on vaccines, okay? So Samir just pointed out that Nova Scotia has the highest rate of influenza vaccination in Canada. Anybody know why? Because most influenza vaccine is delivered by family physicians in Nova Scotia. And in Nova Scotia, family physicians are paid $18.50 to deliver a dose of flu vaccine. Do you know what family physicians are paid in Ontario? $4.50, right? Of course there's a difference. You know, money talks. We have a system in Ontario in which if you are developing renal failure, the government will not pay for hepatitis B vaccine until you're on dialysis. This is plainly stupid, okay? People don't respond to hepatitis B vaccine when they're on dialysis. And everybody who's in renal failure going to end up on dialysis, okay? We should be vaccinating them first. Not only do we not do that, but then we say, well, the government will pay for 1 dose, but the dialysis center has to pay for the other 2 doses, okay? This is not sensible, putting those of us in healthcare, provision of care, in charge of prevention. We do it badly, okay? There's a whole bunch of systems. The last big system is our total budget for vaccine procurement in Ontario, all vaccines, is about what we pay for Remicade. Now, Remicade is an expensive drug, okay? But it's also an effective drug, okay? Nobody's arguing about paying for Remicade. Well, Mail's arguing about paying for Remicade, but we've all agreed that paying for Remicade is cost effective and sensible, and we ought to be paying for it. But we're not paying for a whole bunch of vaccines that are more cost effective than Remicade. And that's a system level thing, because when you buy vaccines, it's a line item and it looks like a lot of money, whereas just when you okay drugs, it's like, well, people will use them and you don't have control over it. And so, if we gave Shingrix to everybody over 65 in the province in 1 year, that would be about twice as much as we pay for a year of Remicade. And we're not going to do that. We're not going to do that because we can't bear to do that, because it's so much money to spend on a vaccine. But it might actually be more sensible than paying for a year of Remicade. Okay, so, and this gets us down to, right, this is a fundamental double standard about what we're willing to pay for prevention and what we're willing to pay for treatment. Okay, there's a bunch of other double standards that play into this, okay, and my favorite of them is the one that Samir's already brought up among his patients. Not just patients, right? How many of you have either thought or listened to another healthcare provider say to you, the pneumonia shot or the flu shot doesn't work well enough for me to get vaccinated? Everybody, right? And it's true, okay? Influenza vaccine reduces your chances of influenza by 25 to 60%. Pneumonia vaccine reduces your chances of invasive pneumococcal disease by about 50%, okay? They are not the world's greatest vaccines. So let's talk about some other preventive things we do in healthcare, okay? Statins reduce your risk of a heart attack by 28%. Lowering your blood pressure reduces your risk of a heart attack by about 20% and stroke by 35 or 40%, right? So we do all sorts of other things in prevention that have a really limited but critically important impact, okay? And we argue about these things. We argue about the cost effectiveness in different populations. There's all sorts of arguments about these preventive interventions and how we ought to be using them. But what we never do is say, oh, I'm not going to give this patient antihypertensives because it only works to reduce heart attacks 20% of the time, right? Ever. That would be stupid, okay? But when somebody says that to you about a vaccine, you do not look at them and say, well, that's dumb. But it is, okay? So everywhere you turn, thinking about what we do about vaccines, you run into this systematic double standard about how we think about prevention and how we think about spending money. And that's really the most important issue, right? That we need to think about how we apply those double standards and how we can get past them. Okay. The last thing, this is my favorite T-shirt of this year. What I want, though, is 20 years from now, okay, so probably when I'm no longer here, this is the T-shirt I want, okay? Because the lovely thing about this T-shirt is it's absolutely true, okay? Vaccines directly cause adults. And if we can learn a vaccination system for adults, then this T-shirt would also be true. So I think the last message is, this is what people in the system call a wicked problem, okay? Wicked, not in the sense of evil, but in the sense of complicated. There is no easy solution to adult vaccination. If there were an easy solution, we'd have figured it out and done it, okay? It's a long, difficult, complex problem. That's the bad news. The good news is that every little piece that you can do, whether it's recommending vaccination to a friend or a neighbor or a patient, or thinking about one small thing you can do in your role that's going to make a difference to how a particular vaccine is used, that is what sums over time to build the system we want for adult vaccination. Thank you.
That was excellent. Thank you so much. Could we have all our panelists come and sit at the front here? And I'll stand here to to moderate some questions. Thank you all so much for being here. So we have some questions that people have already sort of sent in for us to ask, and I acquired a few more in the ladies' room, as you do when you're a scientist and you are in line at the ladies' room. So I'll sort of start the session by asking our panelists some of the ones that people have asked us to ask them. But if anyone has a question they'd also like to ask, just put up your hand and we'd really like to hear from you. Okay, so there's been a lot of questions directed towards Bev, understandably. So Bev, I was hoping that you could tell us if you've had any issues with access to the flu or pneumonia vaccines,
No.
and if you've got any advice for healthcare professionals on how they would deal with older adults or how they would promote this to older adults.
Promote this? Well, I'm very fortunate. My doctor's very thorough, and also my pharmacist. And I've been to both for my flu shot, more for convenience with the pharmacist. I was surprised to hear that some of them here don't. And I think that is sad, because my granddaughters, they went to a pharmacist. And, you know, they get their flu shots as well to help keep me healthy. I don't really know how to tell you what to do other than verbal. We have to talk, we have to educate. And I think what you're doing here today is phenomenal. The word has to get out. It has certainly helped me. Certainly has helped me, because I'm one of the few, I'm up to date. And I
believe.
I'm up to date. Yeah, no, I have good cause to be up to date.
That's great.
Yeah.
Thank you, Bev. I think we have a question at the back. Oh, yes. Oh, you're the moderator. Okay, sorry. All right, we do have a microphone if anyone does have a question. We've also had a couple questions for Dr. Sinha. You know, from your perspective, if these vaccines work well enough to be recommended to older adults, why are more of them not getting vaccinated? And maybe as a follow-up from that, what sort of government policies could we put in place to encourage older adults to get vaccinated?
Yeah, I think the challenge is that, you know, as I think it was Allison and my colleagues were saying, you know, the evidence is clear, you know, that we should be doing this. I think the challenge is that, you know, we go back to some root causes here. We don't actually mandate training and care of the elderly in our medical schools, in our schools of nursing, et cetera. So even one of my colleagues here just said, you know, I don't even know if they're an older adult themselves, and they just said, I don't even know if there's actually a chart out there that tells me what are the vaccinations I should get as an older person. They don't make it clear to me that I need to get my tetanus updated every 10 years. So even for those like Bev, for example, who want to stay, you know, up to date and engaged, you know, you think you're up to date, you probably are up to date.
I was just told I was.
Exactly. But the key is, how do we allow people to make sure they are up to date so that there isn't that 88%, 3% gap in that way? And I think then it comes back to the policies. I think Allison really kind of encapsulated that really well, that we have these fundamental double standards, right? That, you know, we'll actually pay a lot more for something that achieves a lot less, in my view, than basic things, because sometimes vaccinations aren't sexy, right? You know, it's not a gamma knife, it's not a helicopter, it's not, but, you know, the key is that there is enough effectiveness to say, you know, how do we think about those fundamental barriers? And I think some of the evidence we've been finding is, you know, Bev just told us, the convenience of getting it at your local pharmacy. Well, that's worked for Bev. And in provinces where they do that, it works, for a lot of people. In places where you might pay, someone a bit, in financial incentives do work, to get people to do more. I'm not saying that that should be our number one policy, pay people more, and therefore we need to get it. Because I think fundamentally, I don't get paid to do that. Well, I don't choose to get paid to do vaccinations. I've had good training that's taught me that should be a fundamental part of good care for older people. And I think if we actually go that way, we'll actually change practice.
That's great. So I had a question from someone in the audience who's a provider. And one of the myths about vaccines out there is that they can be unsafe, or the adjuvants in them are unsafe, or there's preservatives that are unsafe. Less an issue maybe for vaccines for older adults than younger adults. But for those of you who administer to patients, maybe Dr. McGreer could comment on this. Do you have any language or any terminology that could help healthcare providers sort of address those fears that some of us in the scientific community feel are quite unvalidated about the safety of vaccines?
So I'm in the fortunate place of not being a public health person, and I think the most effective thing I've found with non-healthcare people is to talk to them about our public health system and what it does. I remember a phone conversation some years ago with a journalist who was on about, all of the dangerous chemicals in vaccines and the awful things and the fact that we weren't doing enough surveillance. And eventually I said to him, something, these are vaccines that are recommended by the Public Health Agency of Canada. Public health professionals are people who dedicate their lives. Their entire job is to make sure that you live a safer and healthier life. And they are dedicated to that. How is it that you can imagine that these are people who would allow toxins to be put in your body? And there's this dead silence, and he says, "Oh, I suppose that's true." So I do think that talking to people about the strengths of our public health system and the care that goes into into making sure that our vaccines are safe is critically important, and it's one reason why people in public health and in vaccines spend so much time worrying about the safety of vaccines and trying to build better systems for ensuring that we know about safety. On the other hand, there's so much access on the internet to vaccines are unsafe now. That it really takes a lot of ongoing conversation, and it's a natural instinct, right? The moment somebody says to you, "vaccine," your brainstem responds with risk. Okay, it's the same thing that happens when people talk about flying airplanes and doing other things, right? There was a reason. I don't think there's a reason anymore, but there was a reason why we have this brainstem response to risk. It's supposed to protect us. And because you immediately go to risk, it's very hard to get people off that.
Yeah, great. Thank you. Dr. Crocroft, you addressed the sort of family aspect of that. Do you have any language that you could help those in the audience who are healthcare providers about mitigating risk, or how to deal with the risk, or public perception about vaccines being safe or unsafe?
I think that the fundamental thing is really having a good relationship, and that leads to everything else. So if the patient has a good relationship with their physician, then they can have those conversations about, how we ensure that vaccines are safe. I think understanding the risks of the diseases is really important, because, as Alison said, you think straight away about the risk of the vaccine, but not about the risk of the disease, which, as we've heard, is tremendous. And I also, there's a risk to the person, but then when you start talking about what about your kids, what about your grandkids, then it also becomes people don't want to hurt anybody else. So that part of that conversation, I think, it's very natural. I think some of the way we talk about vaccines is also the whole narrative about how vaccines work could borrow from the homeopathy world. That might sound like an odd thing to say, but because the evidence base for homeopathy actually being effective, safe, yes, but effective, there isn't good evidence. So, but if you read about homeopathy, it's the narratives about how you work with somebody's body to try and address some of the health issues and sort of working along with the body in a natural way. If you think about how vaccines work, they are actually working with your body's immune system to help your body help itself. We're not doing something that's completely radically different. We're saying, okay, if you got influenza and you were lucky enough to survive or didn't get terribly sick, your body would make antibodies and cells that would fight that infection. All we're doing with vaccines is the same thing. We're just doing it bypassing the disease bit. We're teaching your body, we're tutoring your body to learn how to protect itself. It's building on nature. We're trying to help nature help you. And that kind of narrative we don't really do very much. We go to the more, science is protecting you, but people don't really care about science. They don't understand what you're talking about. So I think making that conversation more about, this is a preventive thing. One of the reasons I like having immunizations giving in pharmacies is because it's taking it out of the whole medical disease world. So that is part of that narrative. And that's a very narrative thing. On the other side, I think I totally support what both Samir and Alison were saying about really having to have a system. We're trying to get something to everyone, basically. And that's really hard to do. It has to be done like a military campaign, essentially. Like, you can't just say, oh, well, hopefully people will know they want it, and hopefully physicians will remember to remind people to have it. Like, we know it doesn't work. We can see Canada's got one of the most fragmented healthcare systems in the world. It has, the reason that those rates in the UK are better than Canada is because there's a population-based primary care system. Everybody's registered with one practice, and that practice has targets to meet and is paid to deliver immunization, and data collected on how many of that each doctor's patients are immunized, and their data is fed back to that doctor, and they don't do or do not get paid based on targets. Like, it's a really carefully orchestrated system. I was saying I got a phone call a couple of days ago from my pharmacy because last year I went to my pharmacy for my flu shot. This year, shoppers rang me up and left a voicemail saying, we come and get your flu shot. In 11 years in Canada, my family doctor has never asked me about flu immunization or sent me a reminder. That's no criticism. They're busy doing other things, but it's just not there. When I had my kids in Canada, they had, so when I had my kids in the UK, we got reminders from my family doctor because there's a system. And it's an IT system that does it automatically. Nobody has to think, oh, who haven't I seen? Let's pull up their records. Let's type a record. Nothing. It's just automated. So all of those really carefully time motion studied ways of getting people in the door are really, really important.
That's wonderful. Thank you. We had a lot of discussion from all our members about the effect of population aging and some of the side effects of pneumonia hospitalization. So I was wondering if maybe, Dr. Sinha, you could address the fact that how are we going to plan to manage the increased potential for hospitalization from influenza and pneumonia with population demographics? Are we prepared, and what can we do to prepare ourselves?
Yeah, well, I think I just want to build on what was being said before about that notion of trust between your provider, and I think one of the key things, one of the biggest barriers I find is that if 30% of my physician actually 40% of my specialist colleagues and 30% of my primary care colleagues are not getting the vaccination themselves, and I don't think the numbers are that high because my colleagues don't believe in vaccinations or their effectiveness. I just think if they don't prioritize it enough themselves or find a reason to source out a flu shot, then it's really hard when I would look at Bev in the eyes and say, I think you should get it. And she's like, have you? And I'm like, well, I haven't gotten it, right? Because that's why would Bev get it if I'm not getting it myself, right? What's the key thing? So I always think about, I remember this year, Allison and her team had when I was traveling at the time when they had their things, and I had a lot of moral distress because I'm like, how do I get my flu shot? And our clinic nurse, she was like, well, you're giving everybody else, give me my shot too, right? And so we did that because I felt it would be terrible for me in flu season to be recommending my own patients the flu vaccine, because I think it's very effective when I say that I've gotten it myself and I think you need to get it too. So that's one piece. In terms of the issue around capacity, for our hospitals right now, again, what was the big election, one of the big election themes in Ontario this past year? Hallway medicine, right? Hallway medicine. There's a whole narrative. We have a Premier's Council to end hallway medicine. I'm part of one of the tables, supporting that work. And, it's one of those things when you start realizing that, a lot of people think the way to end hallway medicine is to build more hallways, right? Connected to more beds, and I'm very much against that. I'm saying I actually don't think we need more hospitalizations, and I don't think we need more hospital beds. I think if we start looking more upstream around more home and community care, but also more preventative practices that keep people healthy and active, then I don't really think we need to build more beds. I think what we need to do is, again, go more upstream in terms of thinking about things that help keep people out of hospital, and that principally includes vaccinations as well. So, and the nice part is, I think, in a current government in Ontario that's very fiscally oriented, there's actually a lot of good evidence out there to support that actually vaccinations could be a very good strategy to prevent hallway medicine, number one. More home care, can actually keep more people out of long-term care and out of more beds as well. So I think there is opportunities, to start aligning that. But definitely there's good evidence to support this. Again, how do we make a good policy, a policy link that this is not just good for health, but it's also good for our finances too. There's just a question over there.
Oh, wonderful, wonderful.
Hi. Yeah, so I guess I'm looking at your systems approach, and I'm thinking, so for school-age children, we have up until 18, we have the Panorama database in Ontario, we have the enforcement of the Immunization of School Pupils Act, and now ICON that kind of works together. It's an imperfect system, but it works to give us a fair bit of data as to what our coverage rates are like for children. But we don't have that at all for adults, and I'm just wondering, kind of a two-part question as to how you think that affects the data that we actually have for coverage rates. Is that like a true picture of what people actually have? Mm-hmm. And then also, how does that impact our pharmacists, physicians who are giving the immunizations in order to feel confident and comfortable what they're offering? Has their family physician already immunized them with pneumococcal vaccine, or has their pharmacist done it, or who has the record? And I mean, just with your 3% of people that actually know what they have and don't have, mm-hmm. It's a small number that would be trusted to have an accurate record on their own, I guess.
Is that a question for me?
I think so. I'm not sure who wants to answer it. It was a convoluted question, but
I think information is absolutely key, and without the good information, it's really hard to know what is going on. The moment we really rely on the survey by the Public Health Agency of Canada, which is a telephone-based survey, so that's getting increasingly hard to get good information out of, because people don't have landlines, or they're starting to use mobile phones, but people don't answer. Like I never answer surveys when they come through to my phone at home, I have to say. Just ignore, people screen out the calls. So it is hard to know. There has been some work validating some of the health admin data we have at ICES, so using that Jeff Kwong's done a lot of work looking at flu vaccine, using the coding there. And we have billing specific codes for other vaccines we can use. But with the integration with pharmacy data does represent another challenge. So I totally agree. We need some way of getting data on what's going on in adults, and it's going to get harder, not easier, to get that information. I don't have an easy solution, because this is like major IT thing, but the fact is it's a publicly funded healthcare system. We have codes for influenza vaccine administration. We're getting more timely with our health admin data, so I can imagine a situation in the future where using our billing codes, we could extract the information if we could integrate it with what's going on in pharmacy. It's really not rocket science. It just comes back to whether or not there's a will and there's money to do it.
Great. I think we had another question from an audience member.
So I think the emphasis this morning on systems is really well placed, and I think all the speakers have spoken to the need to improve the system. And as someone who works in the system, I'm a researcher, I'm dedicated myself to improving the system, but it seems like it's often a case of one step forward, two steps back. So my example this year would be in Ontario, the flu campaign, there's this new option, it seems new to me anyway, is that there's this high dose vaccine for seniors, right? But the province will only pay for it if you get it from a doctor. So a lot of people have spoken to the value and the role of pharmacies and how much easier it is to go get your flu shot at the pharmacy. So if the province agrees that this is a useful, valid option, why would you make it so hard for people to get it? It doesn't make any sense. Like, what planet was this written on, right? My mom lives in a small northern Ontario town. She doesn't have a family doctor. I told her to get the seniors shot. She can't get it. So now she doesn't have any because she's trying to figure out how to get it. She could have got the shot at the pharmacy 2 months ago.
Who would like to address that tough one?
You
Alison,
want me to
would
walk
like-
into this one?
Sure.
Okay, so you know, no matter what you do with flu vaccine, you're going to do it wrong. Okay, it's one of those first principles of life thing, it is. I think the decision, my guess is, okay, and this is straight up guessing, my guess is the decision was made this year because the Auditor General didn't like a whole lot of things about immunization programs and thought they could be improved, but one of the things the Auditor General really didn't like was waste in the system. And that's a serious problem for influenza vaccine. It's a more serious problem for the high dose vaccine because it's more expensive, and so my guess is the government was thinking one of two things. Either they really wanted to be careful with their supplies of high-dose vaccine and to try to make sure that that it wasn't being wasted in the system and that it was being used appropriately. Or the other thing is that one of the other things I think people have been many physicians have been really angry with the government about is how complicated influenza vaccine is getting, right? There's quadrivalent, trivalent, and high dose, and adjuvant, and this, and that, and the next thing. And it's fine for me, okay? I live and die with influenza, okay? But for an average family physician who's doing everything, it's been really complicated. And so this government's also trying to simplify things. And you're right. We clearly did not do a good job this year with getting it organized and getting it out. The good thing about flu vaccine is you get to go for it next year again, and we can do better. But to me, what that illustrates, the problems this year illustrate two things. First of all, that we aren't focused enough in the system. I would absolutely agree with you that we did not at a provincial level think carefully enough about the decision and the supply and the issues, and that's time and money, right? I've lost where I was going entirely. Okay, but but I also think it's I don't actually think you're right. I think it's like one step forward and 3/4 of a step back. I do think we're making progress, but everything is, and flu vaccine is probably a bad example to use because everything is difficult about flu vaccine.
I went for my flu shot and I got the over 65. I didn't pay.
Right. You got it from your doctor.
And I said, well, I understood I had to pay. And she said, no. There was a way around it, I guess. I don't know, and I'm not going to say a name, but I did not pay. And I was prepared to pay because I did pay for the shingles shot, which was just over $200. I mean,
no, and just, building on Bev and Allison's comments, I think one of the bigger things that I have is that you know, when we get into the nuances of which vaccine do you get and how do you get it, you know, the bigger thing I think that we've also been focusing on, the fact is that, you know, we're still, like, even if you didn't have the high dose vaccination available this year, our vaccination rates are still terrible, right? And we don't even have a good process to make sure that people are reliably getting it through their primary care, you know, office, through a hospital, or through their local pharmacy. So, you know, I'm always kind of debating in my mind, like, why are we bringing new elements to confuse everyone in the system? You know, I'm not against, you know, better things coming on the market. I'll be clear about that. But it's almost the idea that we need to fix some fundamental issues, and then, you know, and then if we have a system where wastage isn't an issue, when we have infographics from the Ministry of Health that don't forget to mention the flu shot, like, that's the bigger concern I had. Then there's the issue of wastage, and then there's the issue of the other things. Like, how do we actually get those fundamental things right, and then we can say what's the best way to do it. But I think also one of the things that I've been a bit annoyed about is that when you put market forces into certain vaccinations, you know, as a physician with my patient, where there's a lot of trust available, I will look at my patients and I will recommend which vaccination I want them to get. And I'll say, you know, get this at your pharmacy or get this here. And what I don't appreciate is when a pharmacist who might have a motivation to upsell, right, will call back, because I'll say to them, you don't need this one, you can get the free one, just that's what you need, especially when they're on low income. And then I get really pissed off when I'm like, how do they dupe my patient who's making choices between food and other things to get this? What did they say to her to change her mind? And it's a little bit too late. And that makes me a bit upset. So how do we make sure that we have a system that really is respecting our patients and giving them the right things? And I think there's still some pieces to work out there too.
That's a great point. We're running out of time, but Dr. Krokoff wanted to quickly address that
Or
point
just
as well.
a quick two quick points. One about healthcare, about systems, and I think we haven't mentioned the vaccine supply part of the system. And that's one of the issues, that's one of the reasons I wasn't involved in the decision about where vaccines were being supplied, but that's one of the reasons that the high-dose vaccine, which you rightly got for free, is only supplied through primary care doctors, because it is very complex to have different streams of vaccines going in different directions for the Ontario government pharmacy. So I would prefer there to be vaccine immunisation centres in healthcare settings, which were supplied by the Ontario government pharmacy. In addition, I think that would be a model we should think about, because we also have a barrier in healthcare where, for example, someone's in Mount Sinai and they want to get a pneumococcal vaccine, and they're going to get sent to their family doctor. Why can't they just have it done there and then? And it's not possible in every hospital. I mean, they may be able to go to the pharmacy in Mount Sinai, but it's just like that model. We have obstetricians who want to give pertussis vaccine to their patients in Mount Sinai. They have to send them to their family doctors. So, so there's a supply system issue we haven't talked about. But one of the reasons it's difficult to put those into hospitals right now is because of healthcare worker hesitancy. I would love hospitals to be champions for immunisation, but so many healthcare workers hesitate. And so what I wanted to mention was this need for healthcare worker training, which I think you might have mentioned, Smith. So we're just trying to get that off the ground at U of T. We just announced a new Centre for Vaccine Preventable Diseases at U of T, and I last week ran a training session for residents. It's a trial needs assessment for residents on immunisation, because I think this is a huge gap. And I'm kind of stunned by the, you know, I mean, I had residents asking me questions, and I'm thinking, how did you get this far in your training and you don't know that, like basic stuff? And these are the people who know the most, like the people who've already qualified and gone out there. I'm not saying they're not pro-immunisation. Lots of physicians, nurses know a huge amount. It's not that, but if they're not interested, then they may really not know enough to be able to counsel their patients. So we have a current people going through the system training need, and we have a huge continuous professional development need for people who are working out there. The immunisation schedule keeps changing, new vaccines coming along, new recommendations,
and we're not meeting that training need, and yet it's vital.
I think we have to wrap it up now, but
Yeah.
thank you so much. I really appreciate it. Hopefully our panelists will be here for a couple minutes afterwards if you'd like to ask them a question. And I'd like to invite George back up here. On behalf of myself, thank you so much for attending. Thank you everyone for coming and being those silent fighters against these infections and promoting vaccination. It really means a lot as a researcher and as a practitioner and as a patient. Thank you.
Wow, I can't believe the time has just flown by. And didn't we have an amazing panelists? Wasn't that great? Thank you all so much, Bev, Natasha, Samir, and Allison. And Dawn is a researcher by day and an MC by day. So Dawn, thank you for doing such a great job moving us along today. Thank you all for attending. After listening to all of our experts, of course, it's easily to say that getting vaccinated is one of the most important things that we can do to protect our health, and yet our vaccination rates are still have a long way to go. And so despite the human and economic toll that it does take. Based on the conversation today, we've been able to glean some of the insights that's needed to make progress, I believe, on this issue. We will be producing, as we do on these policy forums, a white paper will be written with the recommendations coming out of the forum. We'll make sure everybody gets it. It'll be available in hard copy and online, and we'll make sure it gets distributed. And by the way, the Lung Association and our partners in our Lung Health Alliance do use these documents in terms of moving policy change along. So that's been proven. So we'll make sure that's all shared. And as well today, the recording of today will be shared with you as well, which is terrific. Again, I'd be remiss if I didn't thank our partner, the National Institute on Aging, and our sponsors, Catherine Paquette's here from Pfizer Canada, Lynn Sears here from Sanofi Pasteur. Thank you all so much. A couple of things to remember. You didn't know this, but I learned this today, that our speakers are marketers. So helping nature help you, amazing. I love that tagline. And creating older adults. So I think we can really work on that. There you go. And we've got the poster child, right, to prove it. So thank you all very much. Have a great morning.